All right. Thank you, everybody. I don't know if everyone got maybe you guys are the people in the group that did not get my email last night. Obviously not Janet Coral. Unfortunately, she became ill yesterday and lost her voice. And so yesterday, late afternoon, early evening, we found out that she could not give grand rounds. So here I am. Unfortunately, you've heard a lot of my grand rounds already. So I'm going to go with something a little bit very focused. So I do appreciate everyone showing up. But since this is a little off the cuff and I'm not wearing a suit, I'm going to ask everyone to come down. Come on down. Come on down. Join. Yeah. Join. And it's not really an hour-long talk. So if there are questions along the way, please jump right in and we can kind of open this up a little bit as well. So hybrid procedures for congenital heart disease. Man, you guys are... I won't throw stuff. I bet you I should have brought candy. Yeah, more people come up front. Hybrid procedures. So particularly for congenital heart disease. So what are they? All right, so here's some hybrids. All right, we got the Liger. Everyone loves the Liger. But in the top corner there on the left, on your left, is a hybrid procedure room. And these are now very much in vogue in most congenital heart programs. Also in adults? Yes, no? In adult programs, are you seeing the hybrid catheterization labs? This is actually the operating room at Nationwide Children's Hospital. So very common to have in the cath labs now the cameras that move in and out and rotate. But this is actually in the operating room, and that fluoroscopy tube moves in and out and can be brought right in over the operating room table. And so they were very excited about this. And I had the opportunity to work at Nationwide Children's Hospital for about 5 years before coming out here. We did a number of hybrid procedures there. We closed ventricular septal defects periventricularly in the cath lab. Same with atrial septal defects, intraoperative vascular stenting for the pulmonary artery and coarctation of the aorta. Obviously, everyone's putting valves in percutaneously. But the big thing in Columbus was the hybrid stage 1 palliation for hypoplastic left heart syndrome. So one of the things we have to do is very quickly just kind of talk a little bit about hypoplastic left heart and how it's traditionally repaired, and then how the hybrid works into that. Traditional treatment of congenital heart disease, there's a collaboration between the interventional cardiologist and the cardiothoracic surgeons. So these patients are constantly going back and forth between the OR and the cath lab. Many times the OR is ready in case something happens in the cath lab. But for the most part, the work is done sequentially. Patient will go to the OR, have a surgery, and then follow up in the cath lab to see how the surgery went, and come back to the cath lab before the next stage of surgery to see how things are and whether the patient's appropriate to go for the next stage of repair. But it's always this back and forth. With the hybrid, obviously, you have the same collaboration between the teams, but everything's performed in one procedure. You have both catheterization, fluoroscopy, and an interventional procedure along with a surgical procedure. Try to do it minimally invasive if possible. Intraoperative imaging is often used, and because we're not using bypass most of the time, often done on a beating heart as well. Advantages of hybrid procedures might reduce the number of therapeutic interventions, so you may reduce the number of catheterizations and or surgeries, which will decrease the amount of anesthesia that these developing babies will undergo. You can reduce the invasiveness of the intervention with smaller incisions, avoid cardiopulmonary bypass, and maybe increase the effectiveness of the therapy. And again, you get to build these real fancy, high-tech, cool operating rooms. So let's go hypoplastic left heart just for a minute. So here's the underdeveloped left ventricle with no way for the blood to come out. And then you have the atretic aorta, where number 4 is pointing to. So all the blood comes out of the right ventricle, goes out. This is in utero, and then we have to transition, right? So the blood's going to go out the right ventricle through the pulmonary artery, and then some of the blood will go through the ductus arteriosus to supply blood flow retrograde to the heart, and then up to the cerebral artery, the carotid arteries, and then the brain. And then some of the blood can go to the lungs as well. And then all the blood is returned through the vena cava. Blood returning from the pulmonary veins has to come through the PFO. And then everything is returned to the right ventricle again. So nothing's going to the left side. And this is a classic ductal-dependent systemic blood flow circulation with parallel circulation, which leads to hypoxemia and volume overload. So when these babies are born, the key here is you have to keep the ductus arteriosus open, so with prostaglandins. Before these were prepared, babies went home, and over a short period of time, the ductus arteriosus would close, and that would be the cause of death. But even with the ductus arteriosus open, the problem with parallel circulation is twofold. Babies are blue, and the heart is volume overloaded by definition, because that one ventricle has to pump 2 circulations. So generally, what's the goal of repair of hypoplastic left heart? It's done in stages. So stage 1 is to just stabilize the pulmonary blood flow and the systemic blood flow. But these circulations will still be in parallel, and this is done in the neonatal period within the first 7 days of life. Babies then come back later for stage 2, typically either the Glenn or a modified bidirectional Glenn where you're taking the SVC and hooking it directly up to the pulmonary artery. And this is a staged attempt to begin to separate the circulation, unload volume from the right ventricle. And then stage 3, taking the inferior vena cava, hooking it up to the pulmonary artery. And this completes the transition from a parallel circulation to a series circulation, which is what I believe we all have in the room. So let's just focus in on the stage 1. This isn't going to be a whole thing on hypoplastic left heart. So a classic stage 1 repair, or the Norwood repair, you have a creation of the neo-aorta. So using the pulmonary, main pulmonary artery and the right ventricular outflow tract to create a neo-aorta, usually with some patch material. And then that stabilizes the systemic blood flow. And then you have to stabilize the pulmonary blood flow, and that's going to be done typically either with a modified Blalock-Taussig shunt. So the BT shunt, you can see they're going from subclavian to pulmonary artery. At our institution, some of the surgeons choose to do a Sano modification to this procedure. So instead of the BT shunt, they'll put a conduit directly from the right ventricle to the pulmonary artery. And then there has to be an atrial septectomy that's performed to open up blood flow, so blood returning from the lungs can get from the LA to the RA to then go to the systemic ventricle. So in this situation, obviously you need bypass. There's going to be cardiac arrest. Oftentimes there's going to be either deep hypothermic circulatory arrest or at least some directed blood flow up the cerebral vasculature. There's no improvement in physiology here. Right? This is still parallel circulation. All we're doing is saying, okay, blood can now come out to the body. There we go, back again. And we don't need any prostaglandins, right? Because you can't go to kindergarten on prostaglandins. But still parallel circulation, and these babies will have to come back twice for at least 2 more surgeries to complete the transition. So you're going to put a neonate with a bad heart on bypass with all the trimmings that come along with that. You're going to give a myocardial insult on top of the volume overload to the single ventricle. The neurologic risks associated with bypass and deep hypothermic circulatory arrest, and 2 more pump runs. And then here's just a picture of the Sando modification, right? So you see the RV to PA conduit there. What's the advantage here? Some surgeons will feel maybe some improved diastolic blood pressure, maybe improved pulmonary artery growth. Question whether there's really improved 12-month survival or not. Again, same problems as the classic Nord, or the classic Nord with the modified BT shunt. So the team in Columbus wanted to try to figure out a way to get around some of these insults. And so Mark Galanowitz and John Cheatham really became kind of the ones that pushed this procedure forward to a large extent. They didn't develop the procedure, but they really worked at pushing this forward. This is the surgery of choice for hypoplastic left heart. The original idea was to have one bypass surgery to repair hypoplastic left heart. So the hybrid procedure is not done on bypass, and then you would defer stage 2 until about 6 months of age, and this would be a comprehensive stage 2 repair. So it would be at the stage 2 where the surgeons would both create a neo-aorta as well as do the Glenn. So it was a massive surgery. And then their hope was to come back to the cath lab at age 2 years and do a Fontan, but instead of surgically hooking up the IVC to the pulmonary artery, they wanted to take a covered stent and they would poke through the IVC into the right atrium and open up a covered stent, and that would be, yeah, I didn't do this one. And then that would be the Fontan. I believe they did it in like 1 or 2 patients, and then the FDA shut them down because it's a little bit stretch of a covered stent for a Fontan. Anyway, so let's look at the actual hybrid stage 1 palliation. So the babies are brought into the cath lab, and the midline sternotomy is done. Bilateral bands are placed on the pulmonary artery. This is done to protect the vascular bed and balance the circulations. So the whole idea of single ventricle physiology in a parallel circulation is that if let's say I'm a red blood cell and I have to come out of the right ventricle and I reach that point where I go either to the body or to the lungs, right? That's the definition of the parallel circulation. Which way does the blood go? It's going to go the path of least resistance. Typically, that's going to be the lungs. And so if left kind of to their own, as PVR drops in the newborn period, you may have more blood circulating to the lungs. And so you might have a very pink baby that might have saturations in the low 90s, but that's going to put a lot of workload. Their QP, QS, their blood flow ratios between the pulmonary and systemic blood flows is going to be very unbalanced. It might be 3 or 4 or 5 to 1 to get your sats that high. So that's a ventricle that's going to be very volume overloaded, might be very pink, but you're taking all this blood flow at the expense of systemic perfusion. All right, so you got to put the bands on the arteries, on the pulmonary arteries, to kind of control how much blood flow is going out to the lungs. In the classic repair, that's done by sizing the shunt, right? And the shunt's not going to dilate or constrict, so you size the shunt to control the blood flow. Here you're using the bands to control pulmonary blood flow and maintain systemic blood flow. And then a stent is placed in the ductus arteriosus. And that's essentially your, quote, neo-aorta for the next 3 to 6 months. And then you have to create an unrestricted atrial septum. That's done with a balloon atrial septostomy. All right, so you can see the physiology here is going to be essentially the same, maybe. That's the idea. So you can use this for any single ventricle, essentially, and then follow it with the comprehensive stage 2. Might be the feeling was this was going to be very effective for small or premature infants. So we know infants coming for a classic stage 1 repair that are premature or low birth weights of under about 2.5 kilos are very high risk to take those patients and do a 5, 6, 8 hour bypass surgery. There was hope that maybe there'd be with some patients possibility to wait and go to 2 ventricle repairs and could also be used as a bridge to transplantation. Again, some high-risk patients. And then what kind of grew out of this was an exclusion criteria, and I'll show you why we started excluding some patients from this. But if they had insufficient retrograde arch perfusion or blood flow, that's probably patients that shouldn't come for a hybrid. So we decided we'd look at our anesthetic experience, and this is how we did it. So they come into the cath lab and really just kind of standard monitors with an esophageal temp probe, and that helped the interventional cardiologist know where to put the duct exactly. We did put in an arterial catheter, preferably in the right radial artery, so that we could watch blood pressure to both the heart and brain, and we used cerebral oximetry as well. We kind of divided the surgery into 4 phases: induction and intubation, dissection and PA banding, ductal stent deployment, and then chest closure and transport to the CI. Most of the patients came with a native airway, so we would induce them with fentanyl, 3 to 5 mics per kilo, rocuronium or pancuronium. Maintenance was with isoflurane, and the average fentanyl dose for this surgery was about 5 or 6 mics per kilo. With just to give you some comparison, in a Norwood or any other newborn coming for cardiac surgery, typically we're using doses of 15, 20, 40, 50 mics per kilo of fentanyl. So a much less invasive procedure than the initial Norwood. And then the whole idea here is we have to balance QPQS. A lot of times you can do that just with the use of oxygen. We try to use low FiO2 so as to not vasodilate the pulmonary vascular bed and start unbalancing the circulation. Used to use a lot of subambient oxygen or CO2, and we kind of moved away from that. You can kind of do a poor man's, just by hypoventilating a little bit and drive the CO2 up. You can keep the pulmonary vascular bed a little tighter if you need to. And so then things got a little more exciting. The surgeon had to put the PA bands on. He always put the right-sided band on first because it was easier and less disruptive, because when he went to the left side, sometimes we would get arrhythmia. As he was poking around the left atrial appendage, we could get SVT. Might compress the PDA with his fingers, and we would get hypotension, and we would see that with changes both in our arterial line and or our cerebral vascular monitoring, so on NIRS. Typically, patients would need a little bit of volume. Only about 25-30% of them needed blood. Again, all patients going for Norwood get blood transfusions. All of them, every single one. Inotropic agents were not commonly used here. And again, all patients coming out of the Norwood are going to be on at least milrinone and epinephrine, and a lot of them are on vasopressin as well. They tend to tolerate their hypotension a little bit, and unless we saw signs of cerebral desaturation or ST segment changes, a lot of times we were able to ride out a little bit of hypotension. Then the surgeon would tighten up the bands just until we would see an increase in blood pressure or a decrease in oxygen saturation. And here you can see the first column, B is before, or the blue is before the bands are put on, red is after the bands are put on, and then you can just see the bump in blood pressure and the drop in oxygen saturation. And we're looking for SATs between 75 and 80%. So you can see here even a SAT of 80%, pretty good. I think surgeons tend to err on the wrong side of things. A true balance of saturation is 75 to 80, but nobody likes to see a patient with SATs in the 70s. and so they err on the upper side. And then the stent goes in. So the interventional cardiologist placed the ductal stent via the main PA. By cannulating the main PA, the surgeon would cannulate for him, and then the cardiologist would do all their wiring. And here you have to be very careful about retrograde arch obstruction. If they place that stent in the wrong place and jail off the retrograde aorta, that could be a real problem. So sudden changes in cerebral oximetry or hypotension were a problem. And evaluating these patients beforehand by echo became a really important thing because this could happen. So this was one of the first patients. Everyone was excited to do these originally and take all the hypoplasts. You can see the little hole with the white arrow. That's the retrograde aorta. And you can see how the stent would completely obstruct blood flow. And the fact that this has a ruler is not a good prognostic indicator. And so what we discovered was you can detect this preoperatively, or at least the cardiologist. I can't detect this preoperatively, but the cardiologist can. And so if you look on where it's bad, this 3 sign of flow in the aorta where it goes red to blue, and then, so that's an obstructed retrograde aorta. So these patients would come for a Norwood. Can't do the hybrid on this patient because you'll completely cut off that retrograde flow, and then there's no flow going to the brain or the heart. And as opposed to the right side where you see a wide open retrograde arch. And then they close the chest. I can't think of an episode, and I don't think we had any patients that had to have their chest left open, which is a common occurrence after a Norwood. The heart's pretty beat up after a Norwood, and oftentimes patients can't tolerate having their chest closed for a couple of days. You can see about half of patients were extubated in the operating room or in the cath lab. 65% of them were extubated within 24 hours, and within 2 days, the vast majority of patients were extubated up in the ICU. Very few were on inotropes. Pain control was typically done with a fentanyl NCA, or nurse-controlled analgesia, acetaminophen, and Toradol, and the median ICU length of stay was 5 days, which also is a fair bit shorter than the Norwood. So when we looked at how these patients did, the first 77 patients, there were no intraoperative deaths, although we did perform CPR twice and put 1 patient on ECMO. There were 3 deaths within 24 hours. 2 of these patients were very high risk. One had inborn error of metabolism, the other was Turner's, with an intact atrial septum. There were 4 deaths during the hospitalization for a hybrid stage 1, and there were 11 deaths in the interstage period. And morbidities included necrotizing enterocolitis, strokes, seizures, cardiac arrest, and there were 2 patients that went on to transplant. So, what's the rationale and the advantages here? Well, one, you have a shorter procedure. You have a reasonably stable intraoperative course. You're not putting neonates on bypass, minimizing narcotic and anesthetic exposure compared to the Norwood, relative infrequent use of blood products and inotropic agents, and rapid extubation and short ICU stays. So this was great. Everyone was very excited about this. And really, doing these procedures as an anesthesiologist was much easier and much less stressful than taking these kids for Norwoods. Absolutely. Some limitations. Not sure that this improves survival. There is evidence that myocardial inflammation from having the pulmonary bands on does occur. And there are some mathematical models to suggest that there's decreased systemic delivery of oxygen as well as decreased cerebral delivery of oxygen. So, and then here's just a quick picture of you can see what happens with the comprehensive stage 2, where the SVC is now hooked up to the pulmonary artery. So blood will be returned directly from the upper body to the pulmonary arteries, the IVC still comes and empties out into the right atrium, and now you have your neo-aorta. And this just goes to unload, but this is a huge surgery. This is a massive surgery. Ideally done around 5 months of age. We learned some lessons. When they started doing this, they were bringing the patients in earlier because the kids were kind of teetering off, and so they wanted to get them out of the hybrid and do the surgery. And initially, some of these surgeries would go 10, 12, 14 hours as they were learning how to do them. They did get better. We did get better at it and got these times down to 6 or 7 hours. But these were massive surgeries, and these kids would come back so sick. They would consider a systemic pulmonary shunt if the PAs were small. And after doing the Glenn, after doing the comprehensive stage 2, and before leaving the OR, oftentimes we would do fluoroscopy in the operating room by bringing that camera in. And you can see on picture A, that's a clot in the pulmonary artery. Right, so you can't leave the operating room like that. But if you take a picture and your shot looks like B, then you have a little more confidence that you had a good repair. And by doing these intraoperative angios following the comprehensive stage 2, you can see how the pre-protocol and the post-protocol was improved. So mortality decreased from 19% to 4%. The number of pulmonary artery thromboses went to 0. Number of patients coming off on ECMO, no more. The length of stay didn't seem to improve, but the patients did much better and had fewer complications. So there's been some, in the last couple of years, there's been some meta-analyses and kind of big data studies. So all patients undergoing the comprehensive stage 2 between 2010 and 2016, there were 209 patients. More than half of them had hypoplastic left heart. Overall mortality was about 12.5%, and no real modifiable factors here. So when you look at kind of larger studies, early mortality was significantly higher with the hybrid, with a relative risk of 1.5. Interstage mortality was comparable to the classic repair. 6-month survival, fairly similar. 1 year survival transplant-free, 0.88 for relative risk. And the hybrid patients tended to undergo a lot more interventions. So these kids were coming back to the cath lab, have their, this is after comprehensive stage 2, have their pulmonary arteries rehabbed, stents placed, ballooning, which happens with all of these single ventricle kids, but there's something about putting bands on for 3 to 5 months that may have impinged some of that growth. And what has developed in most centers is that the hybrid procedure has been preferentially used for those high-risk patients. Again, just another STS, some more STS data. Perhaps increased risk of surviving the initial hospitalization, even if the overall survival is not improved. Reduced risk of renal failure following procedure. Not a surprise since these patients are not undergoing bypass. But here with this, in 2015, the Journal of Thoracic Cardiovascular Surgery, looking at 100 centers and 1,700 patients, 13 centers use the hybrid as a first-line surgery, so Nationwide being one of them. Nationwide's not a lower volume center, but a lot of these centers were lower volume centers with poor outcomes. And this always was a question. We did a couple of Norwoods while I was there. And I always wondered, are we doing the hybrid because our Norwoods are no good? Or are Norwoods no good because we're just not doing enough of them? So it does raise a dilemma. What do you do with the kids who can't undergo a hybrid and you have to repair them when you haven't done a Norwood in a year? And you can see some of the unadjusted mortality with higher mortality in the hybrid patients. Still a lot of unanswered questions about this. We saw a lot of patients get neck, so we had to come up with some feeding protocols. Whether there's any benefit neurodevelopmentally with the hybrid is an unanswered question still. But it is being used, and it's being used here as well. We've done a handful of hybrid procedures. I've been elected I've done a lot of them here, not that we do many, but we'll do a couple a year, and these are typically the opposite direction, right? So there are hybrid patients that, or there are nodes, I showed the picture of the small retrograde arch, and so those patients can't go for hybrids, but there are patients that would be very high risk for a Norwood that coming back, you might say, well, let's do a hybrid procedure rather than put this very critically ill baby who's got poor prognosis following the Norwood. We'll do a hybrid and buy some time. And that's typically what it's used for here. It might be a bridge to transplantation for a patient that has no surgical palliative course other than taking the heart out and putting a new one in. And that's typically what we do the hybrids for here. I don't think there's any way possible that the hybrid becomes a standard of care. I think the dream of doing these with one procedure isn't really going to come to fruition. Could it be used as a temporizing to maybe see some growth in the LV, so patients that are kind of borderline hypoplastic left side? Yeah, and we've done that as well. But in terms of this being a long, kind of a taking over and the Norwood, I don't see this happening anytime in the future. But it is used, and it's used in many institutions, again, as a kind of temporizing procedure. So that's it. Something we found interesting. I thank you for coming out today. Any questions?
So that it was your own kid, and or you're a little too young for this, but your grandchild, I'll do that. What would you recommend?
Are you asking me an ethical or medical question?
Yes, both. Yeah.
Look,
You have to make a decision.
yeah, so,
Or to do nothing.
right, so without trying to get into the politics of anything, I would not go through with and the short answer is a lot of the stuff that I do for children, I wouldn't do to my own kid. So if I didn't know that the child had the fetus had hypoplastic left heart and was born, I would probably take home. That is not to say I can put up a lot of pictures of, there's now, the couple of kids that have a hypoplastic left heart. And we have patients here. One is in medical school, and we have a picture of him assisting in an operation on a hypoplastic left heart. I think it's the first hypoplastic left heart to operate on a hypoplastic left heart. So there are some successes. It is a very difficult course. This is not a good disease, and there's and even if you get them through to Fontan, which the vast majority will go through to Fontan, it is a lifetime of complications and ongoing surgeries and the list of medical complications that I'm not going to go into right now. If I was going to do the surgery, I would go the path of Norwood. There can still be some argument that maybe transplant is a smoother course, but nobody's going to, I think, do transplant as a first-line procedure. I think what's going to end up happening is not again for maybe my grandkids or my great-grandkids. This is going to go the way of the dodo, and that we're going to find other ways, whether it's through gene therapy or stem cells, and you're going to grow new hearts right? Some of the best talks that I've seen, they're growing organs, right? So you take a donor organ, you wash it with detergent, get all the cells out, you're just left with the connective tissue, and then you infuse back stem cells from the recipient, and the new heart grows and it beats. And I think once that's there's a lot of, it's fascinating stuff, and there's more and more research being done there, and I think we're just going to either fix it in utero, or we're going to grow them a new heart, because this sucks. It's horrible. So, it's not a great marketing technique, but it's tough, and we all know it's tough. And but
you also raised a really interesting thing that is true across the board in all of medicine. No, not just medicine, but period. That they have to do 50 or something a year to be Israel. And if they don't do 50 a year of it, they're not going to be as good. So even if, it seems to me like if you're in Columbus, you're going to be much better on having a hybrid, because that's what they do.
Correct. So if I was in Columbus and I was going to have this surgery in Columbus, I would have a hybrid. But if I had the means to travel and I was in Columbus, I would go somewhere else. So, all right, cool, thanks.